This is a cadaver study mimicking a procedure that's been very useful to me over the last 10 years, and that is the Transpalpebral Subperiosteal Midface Elevation. Unlike subperiosteal midface elevations, which are approached temporally, providing an oblique vector, the transpalpebral approach assures a vertical elevation. And this vertical elevation has several advantages. It restores a youthful cheek-lid interface, that is, a short lid and a full cheek. And obviously, for that reason, it's very rejuvenative. It's also useful for patients who have had complications after blepharoplasty, where elevation of the midface and, of course, the attached lower lid recruits lower lid tissue. That combined with perhaps lateral canthopexy can correct scleral show and even ectropion. And finally, it can be used with an infraorbital rim implant to reverse the negative vector. This cadaver dissection, again, mimics the operative procedure that has been very useful to me. Surgery is done to a transconjunctival retroseptal approach and an intraoral sulcus approach, and the entire midface soft tissues are degloved in a subperiosteal plane. Now, a subperiosteal dissection is usually considered to be a safe plane to dissect in. It is so in this case also, but with one caveat. Dr. Dumit, who organized and in large part executed this cadaver dissection, made two very interesting and relevant clinical findings, and that is the location of the infraorbital nerve and the zygomatic branch of the facial nerve. He found that in their proximal course of the infraorbital nerve and more distal of the facial nerve, that it lies less than 2 millimeters above the periosteum. Hence, rough dissection, perhaps careless bogey dissection, puts these nerves at risk. The facial nerve is most susceptible when one is freeing the masseteric cutaneous ligaments, and one must free those ligaments to assure an adequate elevation of the midface soft tissues. The infraorbital nerve has on the average 5 branches, some of them running horizontally, and they are at risk when fixation sutures are used to purchase these cheek soft tissues and then later to fix them to the infraorbital rim or implant as the situation demands. So rather than suturing horizontally, it's more prudent to place the stitch in a vertical direction, so you'd have less likelihood of entangling the infraorbital nerve with resultant varying areas of infraorbital nerve anesthesia. In review, the clinical take-home message is to be careful in that subperiosteal dissection, remembering that both branches of the infraorbital nerve and distal branches of the zygomatic branch of the facial nerve are less than 2 millimeters above the periosteum and are vulnerable to damage both during elevation in the subperiosteal plane and suture fixation of the soft tissues.